I'm excited to introduce our speaker today. Dr. Brown is our newest clinical dentist here at Glidewell, but she is not new to dentistry. Dr. Brown joined us this year after 7 years in private practice, where she focused on aesthetic dentistry, and she continues practicing aesthetics while incorporating digital dentistry with in-office milling. Dr. Brown graduated from USC in 2016 and served 5 years on the board of the Western Los Angeles Dental Society and has worked in low-income communities. Dr. Brown is currently the new dentist committee. She is currently on the new dentist committee, where she champions the integration of technology to enhance careers and streamline daily practices. She earned the top 40 under 40 award by the National Dental Association in 2023. Dr. Brown graduated Guiding Leaders in 2023 as well, which is a professional development program that is focused on leadership. Dr. Brown has been a wonderful addition to the Gladwell family. We are very lucky to have her. So without further ado, I will pass this over to Dr. Brown and we can get started.
Thank you so much, Nicole. You make me
Thank
sound
you.
great. Okay, so we're going to go ahead and get started. So today I'm going to be discussing the seamless restorative workflow. So like Nicole said, I joined Glidewell in January of this year. But prior to that, I spent 7 years working in private practice, like she said. When I joined Glidewell, I joined a team that was primarily focused on digital dentistry. So I really work with the IO milling machine, and I do primarily digital work. I haven't actually taken a physical impression since I started here in January. But we implement digital scanning, design, and chairside milling. But before that, I worked in primarily traditional practices where we did a lot of crown and bridge work, but we took traditional impressions. After about a year or two in one of my practices, I started leaning on my owner doctor about we've got to implement a scanner. And when I say I started leaning on him, I mean I was bugging my boss about it. Like, we just got to get this. We've got to implement this. And I was doing it pretty much every day. I was fresh out of school. This doctor had been practicing for over 20 years. And he wasn't really looking forward to making a huge change in his practice. He wasn't looking to purchase anything new. He really kind of wanted to just ride out the end, the last few years of his career without having to make changes. So I really started leaning on him about, let's make some changes in the practice. And we went back and forth about this for months. He would think of some new concern and I would have an answer at the ready. And I'm willing to bet that a lot of his questions and concerns are not that different than a lot of the questions and concerns that a lot of you would be having right now. He would ask, am I going to have to change the way I practice dentistry? And I would say, probably you will. Is this going to make my days a little different? Yeah, things are going to have to change. We'll make some changes, but it will be okay. Will this be worth it? And I would say, absolutely. It's going to be definitely worth it. And is this really the future of dentistry? And we would have these discussions, and these questions kind of came up a lot. Will I have to change the way I practice? Will this be worth it? And is digital really the future of dentistry? And I confidently said yes to all three of those answers. And on 2 out of the 3 of those answers, I was correct. That third answer, though, not quite. Digital scanning is not the future of dentistry. Digital scanning is very much the present of dentistry. Last month at Glidewell, and we are the largest dental lab in the country, so I take a lot of our data I think we can really use to extrapolate and see trends overall. Last month at Glidewell, we received over 160 digital impressions. And you can see this is really kind of the overall trend, with the exception of this small little dip that we have in March and April of 2020, which we won't really get into too much. With the exception of this dip here, you see we've been on a steady increase with receiving digital impressions. Not only have we been seeing an increase in digital impressions, in March of 23, we actually had our crossover point where we here at Glidewell started seeing more digital impressions than conventional impressions. So I was very, very wrong with what I told my boss. Digital scanning is not the future of dentistry. It is the present of dentistry. And as I was having this conversation, I really started to think to myself, well, why? Why have so many dentists adopted digital scanning? So much so that it's the norm now. So I did a bit of research, really for myself, just to kind of inform myself. I searched Facebook groups. I reached out to friends and colleagues. I looked at studies. And time again, I kept coming across the same three reasons of why doctors had implemented digital dentistry. Doctors were looking for an improved patient experience. They were looking to have better communication with their patients and colleagues, and they were looking to have improved outcomes. And interestingly enough, I was also seeing these same three reasons listed for the top benefits that doctors have experienced since they switched over to digital dentistry. So with the improved patient experience, this one kept coming up a lot, and it was broken up really into two different things, one of which was patient comfort. So if I say to you guys right now, let's take an impression. I did a crown prep on number 19, let's take an impression. This is what most of you will think of. Triple tray, light body, heavy body. Did I capture margins? Have I got it all? PVS? This is what we're thinking of. Nothing really to worry about. But if I said that to a room full of non-dentists, patients, this is what pops into their mind. Patients immediately think of sitting with this in their mouth, 10 minutes, they're gagging, they feel like they're choking. Or what about this? How many times have we all had a patient say, I feel like you were pulling my teeth out when you take the impression out? Or what about the times where we actually have taken the teeth out? We have that periodontally involved tooth that we kind of know maybe shouldn't take an impression on, but we did it anyway. It's a fear for both of us. Or what about the time we manage to get the patient through the impression? They don't gag, they're okay, we don't pull out any teeth, but the impression isn't usable. We've got bubbles, tears, the impression didn't seat all the way. And all I can think is, dang, I have to take this impression again. And now I have to tell the patient that I have to take the impression again. Or not to mention the times that we've gotten through the impression, we don't have any of these issues, but impression didn't work. We have to deliver a crown or attempt to deliver a crown that doesn't fit quite right. So now an appointment where a patient came in and was just expecting the delivery, now I have to surprise them and tell them I have to take yet another impression. But with this, an intraoral scanner, we can replace our triple trays. The scanner fits comfortably in the palm of my hand and honestly looks much less intimidating to the patient. If I tell a patient to open wide for an impression tray, they've got one thing in mind. But if I tell them to open wide for this, which doesn't look that much larger than their electric toothbrush, it's a much less intimidating. They feel much more comfortable with this. Which do you think goes down easier to the patient? And if I miss an area with this, nothing more than a simple rescan. I might have to pack cord in a couple areas and that's fine, but it's not a triple tray and letting the material sit for another 5 minutes. I can rescan a missed area in less than a minute. Much easier to the patient. A lot of times the patient doesn't even realize that I've had to go in and make a correction. This is what leads to a much better patient experience. In addition to comfort, co-diagnosis is one of the reasons that doctors were looking to improve their patient experience. Whenever I take a scan on a patient, I like to sit the patient up as I evaluate that scan. This does one of two things. One, it gives me a little time to make sure that I captured everything. I can evaluate the scan, see if I missed any areas, if there's any concerns, anything I want to address with the patient, anything I want to go over. But it also gives the patient time to see the impression, the scan themselves. It's much easier to visualize things outside of the mouth on the screen for the patient. And since I began doing this, not a single time have I ever had a patient who didn't pause to ask me a question. So I get patients that'll say, well, what's that black spot? What's that going on that tooth? And I can say to them, that's that silver filling. That's that old amalgam that I told you about 6 months ago. That I said, hey, I think we're kind of heading toward a crown. We should start to consider this. Now the patient understands it a little better. And a lot of times I've noticed that patients feel much more comfortable having these conversations because they're leading the conversation. It feels less to them like I'm selling treatment and more like they're pointing out concerns, things that they've noticed. Ortho cases, I've seen a vast increase in my ortho cases because with patients, you get so used to looking at yourself in the mirror that you kind of lose sight of the slight maybe imperfections in your teeth. But when they're able to see it on the screen and they can rotate it and move things around and without their face attached to it, patients are starting to have those conversations. They're pointing out, why does this tooth lean like that? Should it look quite like that? they're leading these conversations and it's improving our ability to co-diagnose. A second benefit that doctors were looking for and doctors also noticed is better communication with colleagues. So before I began to work at Glidewell, I worked in a private practice where we were in a 12-story medical building. And on our floor, I was very lucky. We had an endodontist, a periodontist, we got a prosthodontist, an orthodontist, and we were one of the only general offices on that floor. And on the floor above us, we also had an oral surgery group practice and another endodontist. So we had a real luxury in that office where if ever we had concerns about something, we could call them down. They were so referral based, being specialists, they really didn't hesitate to come down if myself or my mentor had questions. And they would do sort of a chairside consultation and answer any questions the patient had or that we had in real time. 90% of the time, if we called, maybe we had a little bit of a wait, but they were able to come down. Rarely would there be a situation where they couldn't come down immediately. Sometimes you would send the patient for a consultation, which was fine, but with an addition of an intraoral scanner into the office, it really opened up our abilities with that. In those cases, we're able to, with the combination of radiographs and intraoral photos, we can take a complete intraoral scan, and then I can save that data and have that consultation with the specialist on my own without the patient having to wait around. And it actually led to much better consultation results on our end because I'm able to ask questions that I maybe don't want to ask with the patient there. Sometimes there are things that I'm not sure of, that I don't want to sound less than confident in front of my patients. But without the patient there and I've got a complete scan, I can go ahead and have this real in-depth conversation. And one of the things that our scanner offers is an annotation ability where I can go ahead and if I'm having conversations with the patient or if I notice something, I can type a quick note here and then remember to take that to my consultation. Or I can share the file with the specialist and they can go ahead and make those notes themselves and send it back to us and we can communicate back and forth. It's just improved my ability to communicate. I've also been able to use this feature when communicating with the lab as well. I can write down notes on what I think my plan would be or things that I'm considering, and they're able to discuss back and forth with this file and this ability. And without a doubt, the number one benefit that doctors were looking for and that doctors noticed with digital dentistry is improved patient outcomes. So let's go back to this image for a second. Let's say that we didn't catch any of these issues with the impression and we sent it to the lab. Or let's say we took a great impression. Our impression looks fine, but we get this back from the lab. You got this red note. And I don't know about you guys, but with the exception of like Lunar New Year, I never want any red envelope. It never says anything good. We can see on this case, we were under-reduced. I personally have had this problem multiple times. My mentor, I believe, is on the call and he will vouch for that. That was often my issue, was under reduction. And at Glidewell, that's one of the biggest things that we hear from the restorative department is a very common thing. Doctors across the board are under reducing. But let's just say we took a physical PVS impression and sent this off. We get this back. And now I know I have to spot reduce. I have to explain to the patient that in order to make my crown fit, I now have to adjust another tooth. I don't know about you, but that's a very uncomfortable conversation for me. Because in my mind, the patient is thinking, you didn't do your job. You didn't do what you were supposed to do. And I feel that as well. And originally I would say the lab needs more room. The lab needs a little extra space, but now I'm my own lab, so I don't really have that luxury anymore. So I'm trying to pull back on that. Or what about this? Maybe your lab takes pity on you and sends you reduction copings. Hopefully these teeth are endodontically treated. Because I don't know about you, I typically try not to numb for my delivery appointments. But if I have this and these teeth are not endo treated, well, now I have to numb. And now I have to explain to the patient that what they thought was going to be a simple delivery, I have to anesthetize you. Now I have to reduce these teeth. Hopefully we have enough room for that. A lot of times we don't reduce enough because we feel we're close to the nerve. So maybe I was close and that's why I stopped and the patient came and they have no pain, great. but now I have to reduce further. And now I have to have a discussion with the patient that you might end up needing a root canal, even though I thought you didn't. Another uncomfortable conversation. But with the use of an intraoral scanner, we are able to fully inspect our impressions with the 3D model before either milling the case ourselves or sending it to the lab. I'm able to see in real time any areas where I may be under-reduced, and I'm able to make adjustments to the scan right there. Even better, I'm able to selectively rescan. So if I'm a little under-reduced on the occlusion, I can go ahead and adjust that area and move on. So we are seeing these trends at Glidewell, which I think are exemplary of what we're seeing worldwide again. Because remember, Glidewell is the largest lab in the world. So if we're seeing these trends here, we can assume we're seeing them everywhere. And I know a downward arrow typically points to something negative, but in this case, I love this down arrow. We are seeing 12% fewer returns with digital impressions. We are seeing 28% fewer seating time complaints with digital impressions. And most importantly, we are seeing 47% fewer fit complaints with digital impressions. So this is telling us that we're getting much better restorations with digital scanning. Now, whether that's because we have the ability to see our models on screen, and I don't know about you, but the first time I saw a 15 distal lingual on screen, I made some changes to how I prepped. So whether it's because of that or because the technology is so advanced and so precise, the lab is able to make us much better fitting restorations. Either way, we're seeing much better outcomes with digital scanning compared to traditional. So now that we have discussed the why, it's time to discuss the how. So let's get to know our scanner just a little better. So the easiest way to think of an intraoral scanner is that it's nothing more than a slightly more advanced intraoral camera. So I'm assuming that we're all using intraoral cameras. If not, we really need to get on board with that. Our Medic i700 can scan up to 70 high definition frames per second. It utilizes a dual high-speed camera and works really well in low light spaces. And if you have ever had your loop light die on you, you know that the mouth is a low light space. So this scanner is excellent at picking up any data in the mouth. I always tell people really just think of it as a slightly fancier intraoral camera. So as you can see, our scanner works by taking photos, capturing data, and layering these photos on top of each other. And these photos immediately convert into a digital model that is visible on the screen in real time. So these images are stitched together by recognizing previously captured data to align them up with each other. When we use our intraoral camera, we can get one of three types of files. The first type is our STL file. This is the most commonly used file format, and it's generally just a more simplistic file. So you're not going to really use this for too much aesthetic work. The second file type is an OBJ file. We use this for intricate restorative work. It gives us both geometry and color and texture. Unfortunately, the file sizes on an OBJ are really, really large. So a lot of times we tend not to utilize these files. And our last type is a PLY. This gives us detail like color and texture. It provides us with highly realistic images and is very useful in aesthetic dentistry, where the detailed representation of tooth color and texture can help design aesthetically pleasing restorations. However, not all softwares can support PLY files, but Medit does and Glidewell Laboratories do. So this is the file that we tend to talk about the most. And whenever you take a scan, you have the option of which type of file you would like to use or export. And for me, I personally design all my own restorations and I really enjoy it. I consider it like playtime. So that's how I remember which file I need to save and send out, the PLY like play. So just a little tip. So now that we've discussed the how and the why, it's time to really get down to discuss how we're going to use our scanner. And for today's exercise, I'm going to be using the Medit i700. I've taken the time to compile my top 5 scanning tips to make this a seamless transition to scanning for everyone. So tip number 1 is to prepare. So you want to start by preparing your patient. I was a Girl Scout, and that's one of the things they teach us is be prepared. So you're going to be prepared. So you're going to start by ensuring that your prep is the best prep that it can possibly be to scan. Because of the poor prep, you're going to have much more difficulty capturing all that you need to capture. And even then, once you manage to capture it, you're going to have a much more difficult time either fabricating the restoration or having the lab fabricate the restoration. So you want to start by preparing yourself with a very good preparation. A good quality prep includes smooth surfaces, sharp, well-defined margins. You want to make sure that you have a space of at least 0.5 millimeter between the adjacent teeth. And most importantly, you want to have the ability to visualize not just the margins, but the prep walls themselves. A lot of times when we're taking a traditional impression, we just want to make sure that we can see the margin all the way around, not necessarily too concerned with the prep walls, but you want to make sure in a scan that you can visualize the walls as well, because that ensures that we do not have an undercut. If you're sending this to the lab has the ability to block out any undercut that we have when they're fabricating the restoration. But if you're milling the restoration chair side, you don't have that ability to block things out. You can kind of work around it, but you'll wind up with a restoration that doesn't fit as intimately, which is what we're looking for. So I always recommend, as you're reviewing your prep from the occlusal surface with the mirror before you go ahead and start your scan, ensure that you can visualize not just the margins, but the walls of your preparation as well. So now that we've started to prepare, this leads us directly to step 2, which is mine your margins. So it's essential that you have clearly visible margins. So again, with your prep, you want to make sure that you're avoiding a J margin. You want to just have a nice deep chamfer. Here's an image that I think speaks volumes. So we can go ahead and prepare the absolute most beautiful preparation in the world. But if we don't expose the margins before we take the scan, the preparation is moot. We have to remember that at its core, our intraoral scanner is nothing more than a camera. So if we can't see something, the scanner can't see it either. It's easy to kind of think that we got so caught up with technology and how things have advanced. I have fallen victim to the trap of thinking wherever I lack something, technology can make up for it. AI can make up for it. In this case, that's not true. If we can't visualize the margin, our scanner cannot pick up on the margins. So if we're taking a traditional impression, we can rely on the impression material to really flow into the sulcus and reflect the tissue a little bit for us. But with the scanner, we do not have that same luxury. So if we look at this image here, the first no cord image, you can see I have my laser pointer here. If we look at this one, we can see the margins pretty much all the way around. If I were taking a traditional PVS impression, I'd be perfectly fine with this. I could capture the things that I needed to adequately. But if we look at a scan of that, we don't have that. We cannot see the margin all the way around. The mesial here, we can kind of make out a margin. The distal, not so much. So if I were going to take the time to design this restoration myself, maybe I could find the margin, but it would take me a considerable amount of time. And if I were sending this to the lab, they would basically have to guess at where my distal margin lies. And you run a risk of getting a restoration that has an open margin, and then we have to send it back. But if we take the time to pack cord on this exact same prep, you can see down here, the margin is fully visualized all the way around. If you were using a chairside designing software like Fast Design, you can actually rely on AI with this case where they would be able to mark your margins instantly. I wouldn't even have to go in and adjust this. So this is just purely indicative of what you need to see when you are packing cord before you scan your restoration. As far as exposing your margins, again, I typically pack cord. Sometimes, like with an onlay, I try to keep my margins super gingival so that I'm not even really dealing with that. Anterior cases, I pack cord. I try not to pack as deep. Posterior cases, we pack cord as well. I personally utilize a 2-cord technique. So I will start with a size 0 cord or 00, depending upon the tissue and the tissue health. And I'll pack that in the sulcus first to give us a little bit of apical retraction of the gum tissue. I then follow that up with a size 1 or a size 2, again, depending upon the tissue health and how much reflection I need, a larger cord to give us that lateral retraction of the tissue. And as you can see here, with the 1 cord, it would be okay. That second cord really makes the difference. After I place both cords, I have my patient bite down on a compricap. I'm not sure if you guys are familiar with those, but they're just anatomically cut cotton rolls where the patient bites down on that for about 5 minutes. I then return, remove the compricap. I do either have the patient swallow so that we can get some saliva moving, or I'll spray a little water around the tooth before I go ahead and remove that top cord. You want to have a little moisture on that cord before you remove it. If you remove the cord while it's dry, you run the risk of really re-traumatizing that tissue and getting a little bit of bleeding. And now we're kind of back where we started. So I recommend going ahead and getting a little bit of moisture on that cord before you remove it. And with that, I get beautifully exposed margins 100% of the time. So tip number 3. So we have prepared. We have taken care of our margins. Tip number 3 is moisture management. The key I want you guys to remember here is dry teeth equal happy scans. So before I go ahead and scan any of my patients restoratively, I like to utilize what's called an obtrugate. So this provides retraction of the lips and the cheeks. It keeps everything out of the way so that I'm able to move my scanner freely in my patient's mouth. If I'm scanning a prepared tooth, I tend to place gauze folded like an accordion next to the tooth in question. And I utilize my air water syringe to fully dry the teeth prior to scanning. This is a prime example of why I make it a point to fully dry the teeth before I begin to scan. Any moisture that remains on the scanned tooth will lead to bubbles or distortions on the scan. And inevitably, as you guys all know, those bubbles and distortions always occur on the contact of the adjacent tooth or on the margin of our preparation. So just take that extra time to really go ahead and fully dry your tooth before you begin to scan. And then further with the obtrugate, one thing I do want to mention, a lot of times I've seen doctors who do not utilize like an obtrugate and they'll go ahead and attempt to use a Minnesota retractor or a mirror to retract. That's fine when we're doing oral surgery, so extractions or things like that. But with an intraoral scanner, that gives it a lot of light reflection back and it can distort our scan. So I recommend not utilizing mirrors or Minnesota retractors or things like that. Really look into an obtrugate. Or if you don't want to utilize an obtrugate, if you have an isolite or an isodry system that does just the same, or you can use the high volume suction. It's just a little bit more complicated. But the key is making sure that you have a fully dry surface before you begin your scan. So we have prepared. We've taken care of our margins. We've managed the moisture. And now we're going to scan with a plan. So what I like about the Medit scanner is it provides information on the order with which we should capture all data. So remember I said earlier that the 3D model is rendered by stitching together previously captured landmarks. So it's very, very important when you are scanning that you stay consistent in the order with which you scan. So as you can see here on the Medit, the first step is you're going to go ahead and verify that you are on the correct patient, which I have done plenty of times, scan on the wrong patient, or you want to verify that you are scanning the correct tooth, the correct situation. So you're going to go ahead and just do your pre-check. After that, you're going to scan the maxillary arch. You're going to scan the mandibular arch. You're going to scan the occlusion. And this right here allows us to scan any additional data that you may want to include. So for example, if you are doing a patient who has an RPD, you want to make sure that you include a scan with the RPD and without, things like that. You can switch the order and scan the mandible before the maxilla. You can just click on it as you're scanning, or if you want to go ahead and change that order in your system, that's a very easy thing to do as well. I personally just tend to follow the way things are presented to me. So again, I complete my check to make sure that I have the right patient and right information, scan the maxilla, the mandible, and the occlusion. When we begin to scan, there are certain pathways and movements that are important to review. So you want to make sure that you place the scanner head as close as possible to the teeth in question. And regardless of the type of scan that you're doing, you always want to start on the most posterior tooth in that quadrant. When we begin to scan, you want to make sure that you are following the correct movements and motion. So when we scan an occlusal scan, which is our first scan, so whether it's the maxilla or the mandible, you want to position your scanner as far back on the occlusal surface as possible. So grab that last tooth. One tip I do sometimes is I actually start on the second to last tooth and then work my way back to capture that last tooth and then go forward. It just can be a little more comfortable for the patient sometimes. So that's one small tip. But as you are scanning across the occlusion, you're going to hold your scanner flat with the wand tip as close to the teeth as possible. You're going to scan straight across the occlusal surface until you get to the anterior teeth. Now, remember we talked about the scanner works by stitching together data that is already captured. In the posterior region, we have that large occlusal table that the scanner can pick up on. But when we get to the anterior, we lose a lot of that because we just have that small incisal edge. So it's very important when you get to the anterior region, you want to make sure that you're tilting your scanner backwards and forwards just to capture a little bit of that facial and lingual or facial and palatal surface of those anterior teeth to capture a little bit more data to help our scanner stitch it all together. So you're going to go ahead, like I said, and start in the posterior region, work your way across the occlusal table. And as you get to the anterior region, you just want to provide a small little tilt back and forth. After you've captured the occlusal, you want to go ahead and make sure that you capture the entire buccal and lingual surfaces of those same teeth, whether it's the maxilla or the mandible. So you're going to roll over onto the lingual and then to the buccal after, but in a fluid motion. So I personally tend to roll over to the lingual first. It just makes it a little easier to capture the entire lingual surface. So I'll start and I'll work my way around the lingual and then work my way around the buccal. Same thing. With repositioning your scan, it's very important to remember, again, how our scanner works. So it works by capturing data and matching it up with previously captured data. So whenever you move your scanner from one area of the patient's mouth to the next, the scanner will tell you if they recognize where you are and if you can proceed with your scan. So if I go from the occlusal and try to roll over to the lingual, I am looking to make sure that I see this nice green square over the teeth. It lets me know that I am in a correct area. The scanner recognizes where I am and that I can proceed with my scan. If by chance I roll my scanner over and the scanner shows a red rectangle, it's saying that it doesn't recognize where I am. I need to either pause for a second to give the scanner a little time to catch up, which is usually the case, or I need to start in another position. If you need to start in another position, the key to remember is do not turn your scanner off. You can simply remove your scanner from the patient's mouth, place it somewhere else. The scanner knows when to start and when to stop scanning. So if I take my scanner out of the patient's mouth, it will not capture any more data until I return my scanner to a place where it recognizes where I am. So you always want to make sure that you see a green rectangle, not a red rectangle, before you begin scanning. And as we are capturing this interproximal data on the buccal and the lingual, the motion here is you want to make sure that you are rotating your wrist back and forth. So after we've captured the occlusal surface, the buccal, and the lingual, it's time to capture, of both arches, it's time to capture the bite. So what I tend to do here, I have my patient open as wide as possible. I position my scanner as far back in their mouth as possible. And the motion that you're making at this point is you are moving the entire scanner head up and down to capture the occlusal. So we're going to review those three motions before we move on to the maxillary scan. When we are scanning the occlusal surface, we're holding our scanner flat as we capture all of the posteriors. When we get to the anterior, we're going to provide a little tilt. When we capture the buccal and lingual surfaces, that's where we're also capturing those interproximals. We're rotating our scanner. Our wrist is moving back and forth. And as we capture the occlusion, we're going to take the scanner and move the entire scanner head in an up and down wave-like pattern. So now that we've gone over all of that, we're going to go over a scanning demo. So here we are capturing the maxilla, the occlusal surface. As you can see, we have a green square that lets me know the scanner is aware of where we are as we're moving throughout the arch. We're going to pay attention specifically to the scanner head. or the tail, excuse me. We're holding it straight up as I'm capturing all of the occlusal surfaces. As I roll over to the buccal and lingual, or to the lingual here, you can see this nice rotation of my wrist. If you think you have moved far enough to capture the interproximal, you probably have not. You should be giving it a full rotation of your wrist to fully capture all of the interproximal surfaces. A lot of times I tend to have to do this as I move closer toward the anterior as well, especially if patients have a little crowding. You're going to do that same kind of back and forth rotation of your wrist to fully capture all of the interproximal surfaces. We continue along the lingual to the opposite side, making that same motion. Again, the key here is the motion of my wrist and the end of the scanner, which we can see is fully rotating. I will then rotate the scanner over to capture the buccal surfaces and complete with the same motion. Back and forth to capture all of the interproximal contacts. So after you complete the maxillary scan, you are going to do the exact same set of motions on the mandible. You're going to go ahead and scan the occlusal flat. When you get to the anterior, you want to provide a little tilt to the scanner so that you're capturing a little buccal, a little lingual. When you get to the interproximal, you want to rotate your scanner so that you're able, when you get to the buccal and lingual, you want to rotate your scanner to capture the interproximals. And when it's time to scan the occlusion, you're going to go ahead and have the patient bite, and you're going to move the scanner head up and down. So I'm not going to show a capture of the mandibular scan because it is the exact same motion as the maxillary scan, but I am going to use a previously captured mandibular scan to show how to go over, review our scan, and find and correct any areas that we are missing. So with this scan, you can see, I'm going to go ahead and toggle between the different views. I like to evaluate my scan in this green mode. This is called reliability mode. It lets us know any areas that we are missing in high definition. With the MEDIT, you want to have a lime green scan everywhere because those are high resolution images that we've captured. As you can see here, there are a couple of small blue arrows, and these are areas that we missed when we were capturing the scan. Because this is a night guard patient, I need to have the lingual there of number 30. So I'm going to go in and recapture that. It's similar to the capturing the entire scan. I place the scanner on the occlusal surface. As you can see, I have that green box letting me know they know exactly where I am. I'm going to rotate over to the lingual. And as you can see, there's, again, that rotation of the wrist. And in real time, you start to see that area where you had a hole in the scan fill in with first red, then dark green, now this lime green color that's letting me know I've adequately captured the area that I was missing. And it's just that simple to rescan. It would have been the exact same concept if I had an area on the tissue an area on a tooth that I needed to rescan. It's just that simple to rescan. So after we've captured the maxillary scan and the mandibular, it's time to stitch those together and capture the occlusion. So this is what you'll see on the screen when it's time to capture the occlusion. You fully captured both arches, but they are kept apart from each other because the scanner is not sure how to interdigitate these models. So we're going to go ahead and capture the occlusion. I like to have my patient practice before I capture the occlusion. So I have them open, bite, and clench. Clenching is what adequately captures the occlusion. The patients tend, especially when they're numb, to not bite down as hard as they should. So after practicing, I place the scanner as far back in the patient's mouth, have them open, bite, and clench, and I move the wand in an up and down wave-like pattern on one side of the patient's mouth. It turns lime green once we have adequately captured the occlusion. Now, as you can see down here, it lets us know which side we need to capture. So we captured one side, now it's time to do the other, and it's the exact same motion. After practicing, I have the patient open, position the scanner back as far as possible, have them bite and clench. And as they're clenching, I move the model up and down until I get this nice lime green image that lets me know I have adequately captured the occlusion. And the software is now completely confident that they can properly articulate those models. One of the biggest benefits that I utilize with this scanner is this occlusion analysis. I like to scan all of my patients when they show up for recall. So either myself or my hygienist will go ahead and scan all of the patients, especially patients where I have concerns about grinding and clenching. A lot of times patients present with grinding and clenching, and we see the signs and they're not aware that they're doing it. So what I like to do is go ahead and take these periodic scans of the patient, and then I can show them, this is how you started and this is where you are now. Without even explaining it to the patients, we've all been trained to see red and know that red means something is not right, something has changed. It's easier to have the conversations with these patients because now the patient sees it and they're asking, well, why is it red? What has happened? What do I need to do differently? What do I need to change? Again, co-diagnosis, the patients are starting to lead these conversations. So the occlusion analysis is an important skill, an important addition that I use frequently with the scanner. So tip number 5, we have prepared, we have taken care of our margins, we've managed our moisture, we've scanned with a plan, and most importantly, we're going to take charge. And this tip is specifically for the doctors. As a doctor, it is very important, it is vital, it is crucial that you lead your team. If any of you have ever tried to implement something in your office, you'll know that if you do not get your lead assistant on board, it is not going to happen. And your lead assistant most often feels like she's overworked. He or she is overworked. They're undertaking a lot and they really don't think they have time to implement one more thing. But if they see that you are invested and you are involved and you are doing it as well, you're much more likely to get buy-in from them. So when I was in dental school, we took head and neck anatomy and we were broken up into small groups and I was terrified of this class. I wanted no parts of it. I did not want to ever have to touch the body. I had done anatomy in undergrad and I was fine, but something about the concept of a human body just unnerved me. And so in class, my professor said that you have to have one person who's kept clean throughout the entire procedure, the entire session. They could not touch the body. They had to keep the book and take the notes and do all of that. And I immediately volunteered. I will be that person. I don't need to touch the body. We had our first 2 sessions, fine. We got up to session 4, we were fine. And at the end of session 4, my professor called everybody together and reminded us that this was only a 6-week semester, so that next week we were taking midterms. And I realized in that moment, I knew nothing. I had taken all of the notes, but I could not point out anything in the body because I had never gotten my hands dirty. In that moment, I made a quick change and I got my hands dirty, but I understood how important it was that I took charge of my own situation. It wasn't enough that I could delegate and explain to other people what needed to be done. I had to be the one to go in, get my hands dirty, and get the job done. Here at Glidewell, if you purchase a scanner and a mill, we recommend that you mill out, I believe it's 50 restorations before you come to campus and take the advanced course where we give you more tips, just so that you've learned a little bit. And I recommend adopting a similar thing in your office. I would recommend to all doctors setting a time frame. Every scan that comes in for the first month, I would say add an additional 10 minutes to your plan and scan the patient yourself. That way you understand exactly how the scanner works. You understand what needs to be done. You're able to make changes in real time to how you prep. But it also shows your staff that you're fully invested as well. And this is not just something that they're having to do. So that's my number 5 tip, take charge. So we're going to briefly discuss the key elements of a good restorative scan. You want to make sure your scan has good clarity and detail, that the margins are fully visible, you've adequately captured the contacts, and you've got good occlusion. So this is an example of a good scan. With this, we can see that we've got adequate preparation. We have both a crown prep and an onlay prep. So I removed the upper jaw. We can see on the lower where we've prepared for the onlay. I can fully see the margins all the way around. I can see the interproximal contacts, and I can check occlusion on this as well. I'm going to go ahead and remove our mandibular scan and show just the maxillary scan. And you're going to check the same thing. In this case, however, I cannot fully see the margins. There's a small area here on the mesial that I'm able to see that I might not have picked up on an impression. So I'm able to go in less than a minute, I actually went ahead and removed this tissue with a little bit of laser. And in less than a minute, I was able to rescan, and my margins are much better. Unfortunately, we also get a lot of not so good scans to the lab, excuse me. So here in this image, we can see, barring any conversation about the prep, this is just an unclear scan. I don't see any margins. This doctor did not adequately pat cord. I cannot isolate a margin here. What is the lab going to do? Here's another view of this same scan, same problem. I cannot see the margins. This is a case where the doctor did not adequately dry the teeth before taking the scan. So you can see we've got all kind of bubbles and distortions all throughout the entire prep. And once again, I cannot capture a margin. And in fact, it looks like they did not give us that nice deep chamfer that a scanned prep requires. Here's the completely incomplete scan. So I understand sometimes if I were to be scanning for a crown prep on number 3, it's not so important that I have the lingual captured of number 12. And so sometimes we're not as diligent with making sure that we capture everything, but it's very important that you do send the lab an entire scan. You don't have to necessarily worry about having everything in high definition, but you do want to make sure that you have all of the data captured. And this one is my favorite. This is another one that we get often. What likely happened here is the doctor took a scan, was unable to adequately capture an area, and they just continued to rescan over and over again. And what happens in a case like this, the scanner is just stacking more data on top of data on top of data. And what the lab sees is an image that looks like this. So you might see, as the doctor, just the image, but the lab is seeing all of this chatter and excess noise. So I would recommend, if you're having difficulty capturing an area, honestly, it's best to just stop, delete the scan, and start over so that you're not just adding more data on top of data and rendering an image that's really unusable to the lab. So one of the biggest benefits of utilizing a scanner is you are able to have an entirely digital workflow if you so choose. So I can go ahead and scan in the office, utilize the online cloud-based system, and I can send it to the lab of my choosing, whether that's a physical lab, or in my case, I am my own lab technician because I utilize chairside milling. So I can send this to my personal lab. And really, you can do it with just one click. I can use the scanner wand to do everything that I need to do. I can scan and then send it directly from the wand. So with MeditLink, I just want to show how easy it is to do that. So once I've logged into the system, I can go over to my patient cases, select the patient whose case it is, select the correct model. It takes less than a minute to download all of the entire files. I just like to rotate my models and verify that I have everything. I check over on this side that I have everything. PLY, your play file, remember. Select that file and download. After I've downloaded, I then log into Glidewell, my account, upload the file, the digital impression. I include the patient's name, gender, and the date that I would like the case back by, drop the case here. And again, in less than a minute, I'm able to send everything off to the lab. So I wanted to share one of the cases that I have done utilizing an entirely digital workflow. And this is an interesting case because I utilized a digital workflow both chairside and communicating with the lab. So this patient presented to me in the clinic. Patient was missing number 30 and has been missing number 30 for quite some time. Patient was not a candidate for an implant because of the amount of resorption that we're seeing in the ridge, but the patient would like to restore this area with a bridge. However, as I look at this case, I see, and it's much worse in the mouth, the patient has a bit of super eruption on number 3, and it would kind of really compromise the aesthetics of my bridge. So I decided to take a look at number 3 as well. And as you can see, the patient has a large old amalgam. They have a chip on the mesial here. They had number 4 extracted, so they've had some rotation and drifting of the teeth. And all of this gray show through the patient's got a considerable amount of decay. So I discussed with the patient going ahead and replacing or restoring number 3 with a crown, both to correct the aesthetics and the decay at the same time. So I started by going ahead and cleaning out all of the old dentistry and just putting a rough margin on my prep. After I get a rough margin, I like to pack my first cord so I can better visualize my margins myself. I then went ahead and placed a buildup, finalized my prep, made sure I had adequate clearance now so that I would be able to get a final restoration that would not drop down too far into this edentulous space. I then went ahead and milled a chair side biotemp restoration, which I delivered temporarily. And then I started to work on the lower. I went ahead and prepared these 2 teeth for a bridge, packed cord. Again, made sure I had adequate clearance. Yes, I check intraorally and with the scanner as well. And I milled a chair side biotemp bridge. However, there was an area on this scan that I wasn't very comfortable with. So I decided that I wanted to go ahead and send this case, this lower only, to the lab. So I was going to mill and design the maxillary crown myself, but I was going to use that same file to have the lab go ahead and fabricate the bridge on the lower. So I went ahead and milled my own crown, and I had the lab fabricate a bridge for me. And so we were able to combine their workflow and my workflow into one beautiful case. So we went ahead and delivered the crown. Patient eventually is going to have work done on number 5. I know that's probably going in a lot of doctors' minds right now. And we went ahead and delivered the bridge, and they work seamlessly together. They look great together. Patient is happy. I had no issues with delivery or occlusion with utilizing 2 separate workflows. So as a quick recap, you want to prepare, make sure you're setting yourself up for success. You want to mind your margins, take care of the moisture, scan with a plan, and number 5, and most importantly, take charge. Do not let digital dentistry be your cadaver. Thank you.
I'm talking to myself. Great job, Dr. Brown. Thank you so very much.
Thank you, Nicole.
We have some questions for you. Are you ready?
I am ready.
Excellent. So we know that PLY is for play, but can you
Yes.
explain the difference between PLY and OBJ files and what their significance is?
So the biggest difference with an OBJ versus a PLY file is the size of the file. An OBJ does give you a little bit more of a PLY needs you a little bit more of a realistic look to it. or OBJ has a little bit of a cartoonish look to it, but the file size, the OBJ files are so much larger. You tend to have issues with storage or sharing the files. So most offices tend to use the PLY.
Excellent, thank you. Let's see, what is the name of the anatomical cotton roll? I actually put that in the chat for everybody.
Yep.
And then when scanning a fixed bridge, is there a limit on the number of units that can be scanned?
So with scanning, no, but if you are utilizing a chair side mill, you can have an issue with that depending upon your system. So I know with fast mill, we typically will only do 4 units, but that's because of the size of our blocks. We can't we can't mill anything chair side that's larger than that. If you're sending to the lab, you can scan as many units as you want. I've seen roundhouses scanned.
Perfect. So when scanning, do you need to scan the full arch if you're just doing a single crown, or is a quadrant sufficient?
So it depends on the area. So if you're doing a single unit posterior tooth, I recommend going 1 tooth in either direction. So 1 tooth mesial, 1 tooth distal. If it's the most posterior tooth, you want to provide the entire quadrant. That's if we're looking at posterior teeth. In anterior teeth, you want to get that entire anterior segment regardless of the number of teeth.
Excellent. Okay. So can you do a CR or a CO bite to see the slide and the discrepancies?
You can, but again, that's something that you would have to, the system doesn't provide that what's the word I'm looking for? The software doesn't do that itself. You would have to know how to capture those bites, the CR and the CO, and then analyze the data yourself.
Perfect. Okay, that's great. Thank you so much.
Mhm.
Do you have any tips on scanning the gingival tissue around a 4-unit bridge?
Same thing, you want to make sure that you've adequately dried the
Okay.
tissue. If you are having issues, you can use something like an occlude spray. It's not necessary. I typically, if I'm trying to capture gingiva, I will use both the air, but I'll also take gauze and just pat around the tissue. You can have issues when you're doing a longer span, like in a dentulous area, and you're trying to capture the gum tissue. For that, I have seen doctors utilize like an indelible stick or a marker so that you can go ahead and leave a little mark on the tissue so that the scanner has a reference point to pick up on.
Oh, that's a good tip. Okay, so here's another one. Can you scan a second bite registration? For example, if doing an anterior case, can you scan a centric bite as well as a protrusion or edge-to-edge bite for a more accurate incisal length?
You absolutely can. So one of the images that I showed when I was showing the steps of what you should be scanning, so it shows you're going to check the patient first, then the maxilla-mandibular occlusion, and then there's an image of a scanner with a plus sign where you can include any other scans that you want to give. So any additional information that you would want to give to the lab. So you would go ahead, capture your first occlusion, and then click that button, capture a second occlusion, and you can use the annotation feature to let the lab know exactly what this second bite is of.
Perfect. And do you have any tips for managing bleeding?
So I personally I utilize a 1 to 50 anesthetic if I need to capture to control bleeding, or hemodent in my cord. So I use a hemodent packed cord all the time. You can utilize a laser, but that you have to factor in that you're going to have less tissue. You might have to adjust your prep at that point. Um, my coworker I know uses like the I'm blanking on the name of it in the syringe. I am
Oh,
blanking on the name.
I know what you're talking about, but I
Yeah,
can't think it. I'm not
I'm
helping.
blanking. But I will get that message over to the doctor that asked the question.
Traxident.
Tractident, yes, a
Thank
paste.
you,
So
audience.
they go ahead, thank you, and use those. I personally just stick with either a soaked cord, or a 1 to 50 anesthetic.
Excellent. Thank you so much. Okay, this one's kind of subjective, but and it's just kind of a fun question. In your opinion, do you think dentistry will eventually utilize robotics?
I do think that.
Yeah.
Especially because we're starting to, you see it so often in surgeries, like in hospital settings, and it's only a matter of time, I think, before they scale it down enough that we can use it intraorally. So I do think that's coming down the pike. I would be interested to see how that looks, but I do think that's coming down the pike for sure.
Me too. Well, that's it. Thank you so much, Dr. Brown. This is a lot of great
Thank
information.
you.
I'll always remember send to lab, STL, and play. Thank
Play.
you, everyone, for
Exactly.
joining us today. We went a little over on time, but your CE certificate will reflect the additional time. Be sure to join us next week when we'll have, as always, our business advisory panel, and our guest speaker will be Dr. Stacy Pizzuko, and her topic is oral pathology, diagnosing, and treatment. So let's meet back here next week, same time. We'll see you then.
Thank you. Bye.